Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. Let's practice applying what we know about preeclampsia. A 32-year-old client, previously normotensive, has blood pressures of 142 over 98 millimeters of mercury and 146 over 92 millimeters of mercury on 2 separate days this week. She is 28 weeks gestation. The nurse knows the client has developed A. Gestational hypertension, B. HELLP syndrome, C. Chronic hypertension, or D. Gestational diabetes. The best answer for this is A. Gestational hypertension. The reason that A is the best choice is because gestational hypertension is related to the pregnancy and is defined by blood pressures that are greater than 140 systolic or 90 diastolic on more than 2 occasions at least 4 hours apart in a client who was previously normotensive and who is 20 weeks of gestation or greater. The option B of HELLP syndrome. HELLP syndrome is characterized by hemolysis, elevated liver enzymes, and low platelets. This is a very severe form of preeclampsia, and nothing in this story applies to this client. C, the option was chronic hypertension. Chronic hypertension will be those elevated blood pressures, but they'll be identified prior to 20 weeks gestation or prior to becoming pregnant. And then option D was gestational diabetes. Gestational diabetes would be identified by a glucose tolerance test, not by elevated blood pressures, and it would have elevated glucose. So when we think about chronic versus gestational hypertension, hypertension is going to be blood pressures greater than 140 systolic or 90 diastolic on 2 or more occasions more than 4 hours apart. If these blood pressures are elevated prior to 20 weeks gestation, the client has chronic hypertension. If they're elevated after 20 weeks gestation, this is a gestational condition and it is gestational hypertension. So for this client, she has gestational hypertension. Question number 2. A client at 28 weeks of gestation, previously normotensive, has developed gestational hypertension with blood pressures of 142 over 98 millimeters of mercury and 146 over 92 millimeters of mercury on 2 separate days this week. So this is our client from the previous question. Which finding, if present, could be an indication that the client has preeclampsia? A. Mild edema in the ankles. B. Blood pressure reading of 148 over 94 millimeters of mercury. C. Proteinuria. Or D. Mild nausea. The best answer for this is C. Proteinuria. Proteinuria is a key sign of preeclampsia. Gestational hypertension will be the blood pressure greater than 140 over 90 after 20 weeks gestation without proteinuria. But once we have proteinuria, that is a sign of preeclampsia. Other signs can also be seen as well, which we'll look at in a second. So the other options in this question, A, mild edema in the ankles. This is a normal finding during pregnancy, so that wasn't the best choice. Blood pressure reading of 148 over 94 millimeters of mercury. That is an elevated blood pressure, but it's also consistent with what her blood pressures have been reading. So this is a sign that she has gestational hypertension, which we already knew that. But we're looking for a sign that she's developing preeclampsia. And then mild nausea was the other option. And while nausea could be a symptom of preeclampsia, mild nausea in the absence of other symptoms is not a concerning finding. So with preeclampsia, we're going to have that hypertension and then at least one other symptom related to the organ system that's involved. And so we can see the renal insufficiency where we see proteinuria. We can see cerebral symptoms like an unrelenting headache that doesn't go away with treatment. We could see elevated liver function tests, thrombocytopenia, hyperreflexia. There's other symptoms, but that proteinuria is a key one. Question number 3. How would the nurse check for Clonus in a patient with preeclampsia? A. Assess the patellar and bicep tendon with a reflex hammer and grade the reaction. B. Assess for muscular rigidity by having the patient extend the arms and then placing resistance against the arms. C. Assess for beating of the foot when the foot is quickly dorsiflexed. And D. Assessing for dorsiflexion of the foot by quickly plantar flexing the foot. C. Assessing for beating of the foot when the foot is quickly dorsiflexed is the best answer. And so the rationale is because that the clonus is a series of rapid involuntary muscle contractions and relaxations. And so it causes like a twitching. So when you quickly dorsiflex the foot and you let go, as it goes down to its resting point, it twitches. And so this is often seen in the ankle when you briskly dorsiflex the ankle. This is a sign of hyperreflexia, which can be a sign of worsening preeclampsia and an increased risk of seizures because she is very neurologically excitable. Other choices for this were A, assessing the patellar and bicep tendon with a reflex hammer and grading the reaction. Well, while we can use a reflex hammer and assess the deep tendon reflexes, and this is a part of our neurologic assessment, it is not the primary way that we detect clonus. So clonus is specifically those rhythmic muscle contractions, and in order to get that, we have to have that stretch by dorsiflexing the foot. Option B was to assess for muscular rigidity by having the patient extend the arms and placing resistance against the arms. In this one, the assessing muscle tone and strength is not going to give us an indication of clonus. And so this wasn't the best choice. And then D, the option said to assess for dorsiflexion of the foot by quickly plantar flexing the foot. And this is the opposite movement of what we need in order to elicit clonus. So this wasn't the best choice either. Question number 4. A client with preeclampsia develops hyperreflexia and clonus, and the nurse notes the respiratory rate is 14 breaths per minute. The nurse understands these findings indicate A, preeclampsia is resolving, B, the client is experiencing magnesium sulfate toxicity, C, the client is at high risk for seizures, or D, the client is developing eclampsia. The best choice for this answer is C. The client is at high risk for seizures. And the reason for this is because the hyperreflexia and the clonus are signs that we are having a worsening neurologic involvement. And so this puts her at a higher risk of having a seizure. The other options, A, the preeclampsia is resolving. This is indications that it's worsening, not resolving. B, the client is experiencing magnesium toxicity. While we use magnesium to treat preeclampsia and prevent seizures, if she was having toxicity, she would have muscle weakness, respiratory depression, decreased reflexes, and this client's respiratory rate was 14 breaths per minute, which is normal. And then D, the client is developing eclampsia. Eclampsia is going to be the seizure, which is what we would try to prevent. There isn't anything in here that states that she is experiencing a seizure as of yet, but she does have hyperreflexia, which could be a precursor. It's showing us that heightened neurologic involvement. So when we think about things that we might see with worsening preeclampsia, if the preeclampsia is becoming more severe, the blood pressures will be higher, greater than 160 over 110. The proteinuria is worse. We have thrombocytopenia. We have the hyperreflexia. A lot of these different things can happen as this is worsening. Question number 5. A nurse is caring for a pregnant client with severe preeclampsia. Which of the following is the highest priority nursing intervention? A, encourage the client to ambulate to improve circulation. B, administer a dose of oral acetaminophen for headache. C, administer IV magnesium sulfate. Or D, increase the client's fluid intake with juice. For this client, the priority is going to be to administer IV magnesium sulfate. And the reason that this is the priority is because that a client with severe preeclampsia is at risk of having a seizure, and magnesium sulfate is going to be our standard treatment to prevent the seizure. And so this is going to be the important thing to do. Of the other choices, A, encourage the client to ambulate to improve circulation. If our client has severe preeclampsia, we often are limiting their activity, maybe having them on bed rest, doing low stimulation to try to minimize the seizure risk. B, administer a dose of oral acetaminophen for the headache. We can definitely give her acetaminophen, but this is a symptom management technique. This isn't addressing the potential life-threatening issue if she has a seizure. And then the other option was D, to increase her fluid intake with juice. So typically, a patient with severe preeclampsia has an increased risk of fluid volume overload and pulmonary edema. So we actually monitor their fluid intake very closely and we keep them on a fluid restriction. Question number 6. A nurse is monitoring a client on magnesium sulfate for severe preeclampsia. What sign might indicate magnesium toxicity? A, loss of reflexes. B, nausea. C, blurred vision. Or D, headache. Loss of reflexes is the best choice for this question. And the reason is because that magnesium sulfate is a central nervous system depressant. And so signs of toxicity, if our magnesium level is too high, are going to be things where it has really slowed things down. So respiratory depression is a big one, loss of deep tendon reflexes, severe muscle weakness. These things are concerning. And so we assess the deep tendon reflexes at least hourly, and this is a very reliable indicator if we are developing magnesium toxicity. Of the other options, B was nausea, and this might be a side effect that we could see for a patient that's taking magnesium sulfate for preeclampsia, but it's not a toxicity sign. C was blurred vision. Blurred vision could be seen with preeclampsia or other conditions, but does not indicate toxicity specifically. And then headache is also a common symptom of preeclampsia. And so this would not be an indication of magnesium toxicity either. So here, if we look at some of our signs of magnesium toxicity, we're using magnesium to prevent a seizure. Our therapeutic range for magnesium sulfate is 4 to 7 milliequivalents per liter. Our antidote is calcium gluconate. And if we have these signs of toxicity where we have decreased or absent deep tendon reflexes, respiratory depression, altered level of consciousness, lethargy, those things, then we might need to consider giving an antidote if needed. Question number 7. A nurse is caring for a client who has just delivered a baby after being induced due to severe preeclampsia. Which medication should be avoided if the client experiences uterine atony? A, Pitocin. B, Cytotec. C, hydralazine. Or D, Methergin. The correct answer for this question is D, Methergin. And the reason that this medication needs to be avoided for this client is because that Methergin can cause a blood pressure increase by stimulating the smooth muscle in the blood vessels. So for this patient, she's preeclamptic. We don't want to increase her blood pressure more by giving her Methergin. So another uterotonic would be better for her. So Pitocin and Cytotec are both uterotonics that could be used for her. The other medication listed was hydralazine, and hydralazine is not a uterotonic medication. It's a medication used to manage blood pressure with preeclampsia. It wouldn't have an effect on the uterus. Question number 8. A nurse is caring for a 32-year-old client at 36 weeks gestation who's been diagnosed with severe preeclampsia. The client's blood pressure is 168 over 112 millimeters of mercury. She reports a persistent headache and her reflexes are hyperactive. The nurse anticipates the provider will prescribe which medication to control the client's blood pressure. A, labetalol. B, magnesium sulfate. C, oxytocin. or D, Methergin? So labetalol is the best choice for this question. And labetalol is the first-line antihypertensive that we use in pregnancy to reduce severe blood pressure elevations with preeclampsia. The other common medications we could have used for this patient would include nifedipine and hydralazine. Magnesium sulfate was choice B. Magnesium sulfate is going to be used to prevent seizures, and it can have some effect on the blood pressure, but it is not going to be a first-line medication we use to manage the blood pressure specifically. C was oxytocin. Oxytocin is used to induce labor or to control postpartum hemorrhage, but it does not have any role on treating preeclampsia-related hypertension. And then Methergin is the uterotonic that we just talked about on the previous question that's used to treat postpartum hemorrhage, but it's contraindicated for clients with hypertension, so that wouldn't be a choice for her anyway. Question number 9. The nurse is caring for a client at 34 weeks gestation with preeclampsia who's receiving magnesium sulfate for seizure prophylaxis. Which findings should the nurse report to the provider immediately? A, deep tendon reflexes of 2+, B, urine output of 20 milliliters per hour, C, respiratory rate of 18 breaths per minute, or D, warm flushed feeling. The best answer for this one is B, urine output of 20 milliliters per hour. The reason why this is important is because that magnesium is excreted by the kidneys. So if the urine output is less than 30 milliliters per hour, then this is going to put the client at risk for magnesium toxicity because they're not excreting it at an appropriate rate. The other options, A, deep tendon reflexes of 2+ is a normal finding, and we actually like to see that we have deep tendon reflexes. Absence of deep tendon reflexes would be concerning. C, respiratory rate of 18 breaths per minute. This is also normal. We would be concerned if the respiratory rate was less than 12 breaths per minute. And then the warm flush feeling is an expected side effect of magnesium sulfate, so that's not concerning either. Question number 10. A nurse is assessing a client with preeclampsia. Which assessment finding indicates the condition is worsening? A, the blood pressure is 150/90 millimeters of mercury. B, 1+ protein in the urine. C, platelet count of 80,000. Or D, mild dependent edema in the ankles. The best answer for this one is C, platelet count of 80,000. The reason that this is the best choice is because this is an indication of thrombocytopenia, which indicates worsening disease and also possible development of HELLP syndrome. Blood pressure of 150/90, while this is elevated, this is not a severe factor. This is not in the severe range greater than 160/110. 1+ protein in the urine, this is mild. We're concerned if the protein is greater than 3+. And then mild dependent edema is a common pregnancy finding, and it's not specific to the progression of preeclampsia. So to recap preeclampsia as a whole, hypertension is blood pressure greater than 140 systolic over 90 diastolic on more than one assessment at least 4 hours apart. Chronic hypertension begins before 20 weeks gestation. Gestational hypertension begins after 20 weeks gestation. Preeclampsia is going to be that hypertension plus at least one additional symptom related to organ systems that are involved, and this could be the renal system, including proteinuria, oliguria, increased creatinine. This could be the hepatic system, including elevated liver function tests, right upper quadrant or epigastric pain. This could be the neurologic system with headaches, visual changes, and hyperreflexia. And it also could be thrombocytopenia, or platelets less than 100,000. Treatment for preeclampsia is going to be focused on preventing a seizure, so magnesium sulfate, and all of the monitoring that goes along with that to prevent magnesium toxicity. We need to manage the blood pressure, so not depending on magnesium sulfate as our means of keeping the blood pressure down. The primary medication to manage the blood pressure would be labetalol, but nifedipine and hydralazine are also choices. And then close monitoring and probably preparing to deliver. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.